Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have our presenters in conference. Please be aware that each of your line is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly below the presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hund.
Thank you so much. Hello, everybody. Welcome to the March 2021 AHA Team Training Monthly Webinar. Today, we're talking about simple steps for engaging physician partners and sustaining your safety culture with Dr. Jason Cheng. So we'll be meeting him in a second. We'd also like to thank our sponsor, Relias, who you'll be hearing from in a minute as well. But thank you again for joining. This is Chris Hund, Senior Director with the Center for Health Innovation. So just some rules of engagement that are pretty standard for those of you that have joined before. You can listen to the audio for this webinar in two different ways. You can do it through the phone. If you are doing it through the phone, you're going to want to mute your computer speakers, otherwise you'll get some very bad feedback. Or you can listen through your computer. We often tell people that if they have an unstable internet connection, it's better to listen through the phone just so you don't have any audio issues. All hyperlinks on the screen are active if you click on them and will open up in another window for you to review something later on. We'll also have a Q&A session at the end of the presentation. The way that we like to do that is to have you write questions in the chat as we go. And I'll collect those, and then we'll have a nice Q&A at the end with Dr. Cheng. Also to note, you can see on your screen that there is a file pod on your screen. That's where you can download the slides as well as instructions for CE credit. Speaking of CE credit, we have the ability for you to receive one CE credit hour from Duke Health with this webinar. And that counts for CME or CNE, or all of the different allied health professions. So that is something that we offer. To do so, you'll need to set up an account with them if you haven't yet, and then you'll text the code that's on the screen to that number after 1 p.m. Eastern Time today, and that window will be open for 24 hours. So some upcoming team training events that I'd like to turn your attention to. One is a webinar that's going to be on April 14th. That's our next monthly one. It's on design thinking for human-centered healthcare. We also have virtual courses and workshops available, including one that's on engaging patients and families as team members. So that will be a fun 4-week workshop about PFE. And then we'd also like you to join Mighty Network, which is our online community platform. So to access exclusive content, connect with peers, share stories, that's really where you want to go. So just click on that link to join Mighty Network. Okay, the other big announcement we'd like to make is the Advancing Care Conference. So the Advancing Care Conference is a brand new conference offering from the American Hospital Association that will be taking place in person in Chicago from October 4th through 6th. But what makes this an interesting conference is that there's also a pretty large virtual element. So if you want to attend the conference, you'll have access to a variety of online resources starting at the beginning of August. We'll help you select a challenge that you might want to tackle by attending the conference, and utilizing design thinking skills help you put together a plan so that by the time you leave the conference, you have an action plan, you have an ability to prove an ROI of attending, and really you have some sort of way forward on whatever challenge it is that you wanted to tackle with the conference. So I know this is the first time you're hearing about this, but this conference is unlike any other conference that I think people put on. in the fact that it's all about accountability and it's about solving something specific that's bugging you, getting that pebble out of your shoe. So really excited to be able to announce this. Click on that link, and you'll be hearing more about this from us on a monthly basis. Okay, without further ado, I'd like to introduce John Harrington, who's the Director of Acute Solutions from Relias, who is sponsoring this webinar. So, John, I'll toss it over to you to say a few words.
Thank you very much, Chris. It's an honor to be here today. So as you mentioned before, the webinar is sponsored by Relias. Really proud to join you today. We're the provider of online analytics, assessments, and learning for approximately 10,000 healthcare providers across the continuum of care. We offer unrivaled interactive educational content that provides the ability for clients to create their own courses and allows for demonstrations of skill and performance within a single management system. As you can see from this slide, what we do is we help hospitals and healthcare systems improve outcomes and reduce risk. So how do we do that? Everything we do is driven by our core philosophy that follows really three pillars. First and foremost, identifying variation in the competency and care delivered by your teams. Once we have that assessment, that understanding, we derive individualized, personalized learning that rewards competency and tests out of areas where you've demonstrated mastery and conversely tests you into areas where you can improve. And when we do so, we help organizations to create highly reliable teams. We can go to the next slide real quickly. So, thank you. Our solutions actually cover the entire continuum of care. We help organizations to recruit, assess, onboard, train, and retain clinical team members, all based upon this personalized learning process, which really just follows a virtuous cycle of assessment, remediation, and reassessment. So today's presentation is especially relevant to everything we do at Relias. Today, our content is validated by industry partners such as A1 and ENA, and we're in 8 of the 10 largest healthcare systems across the country that use our program to help them improve outcomes and reduce risk. But everything we talked about above was really encapsulated in today's presentation about how you create highly reliable organizations. And so I'm incredibly honored personally to be part of the session today because I have a connection personally with the original DoD grant and study that the Risk Management Foundation of the Harvard Medical Institution employed with Dr. Sachs' team that launched Team Steps. So as you can imagine, for us at Relias, we create highly reliable teams that's really based upon that team dynamic and in creating a shared mental model and a common vision of care. And physician engagement is crucial to doing so. So again, we're really honored to be part of this presentation today. And with that, I will turn it over to Chris. Any of those interested, you can always learn more about us at relias.com. So back to you, Chris. Honored to be here.
John, thanks so much, and it's really great to hear about your history with the Team Steps program. I think that's what's so great about this community is that it's got a lot of history and a lot of people involved really around the world in a variety of places. So everybody check out the Relias information, check out their website. We really appreciate that. So now to the top order of business. I'm here to introduce really a big ally and friend of the program, Dr. Jason Cheng, who is the Safety and Human Factors Education Co-Chair at Kaiser Permanente, Southern California region in the Department of Anesthesiology. And Dr. Cheng has really been a key part of the Team Steps journey, I feel, for many years, presenting at conferences, presenting in other ways, attending events. So pleased to have him here, and I think you're all in for a treat. So, Dr. Cheng, over to you.
Chris, thanks so much. Thanks so much for having. It's just always a pleasure to be here. I first and foremost just want to highlight, that the word human factors education is really a big part of the DNA of why I'm here, and especially, as an anesthesiologist, I think so much of us, know that the journey of human factors and education and safety really has a big part with anesthesia. So it's really a proud privilege for me to be able to present and share this information with you all. So there's going to be a lot of information that I'll share, and you guys can look at this, offline. But I think really the main objectives that I would like to be able to have for you guys all is really how to be able to create and cultivate conversations, from the framework of change management And the conversations, can serve as entry points, to how to engage physicians in your safety culture. And we'll talk really about how to share stories. We're going to talk a little bit about how to be able to frame and understand errors to be able to create a culture of learning. We'll explore a little bit about just how cognitive bias and having a deeper understanding really of our own awareness and how all of that really allows us to be able to kind of embrace a different role of being a leader to being a team leader. What I wanted to highlight right here is I represent one of 23,000, almost 500 physicians across our entire Kaiser Permanente enterprise. And we have memberships and we have family from all the way in Hawaii, as you can see, the entire west coast of the United States, Colorado, as well as some of the states in the East Coast. And we have 64,000 nurses we work with and 12 million members. So really, it is a vast enterprise, and I'm really humbled to be able to represent our organization. But I think one of the most important things, when we try to figure out exactly how to tackle, such an undertaking, is really the most important thing is just to focus on a very few. Focus really on the individuals and those who actually really will lead your change management. I think the most important thing I just wanted to remember is, when we're trying to increment any type of change, management, what we really want to do is focus on those who will be able to lead the change, because we know that there's obviously those who just don't really want to be part of it. And I know even though some of us kind of deal with, some of the challenges or challenging positions, what we really want to focus on are those who are going to be leading the change. And penguins, as you know, are, an important part of the change management journey from John Cotter's work, The Iceberg, Our Iceberg is Melting. Just real quickly, I think one of the most important things is just to understand everybody is at a different place. I think those of us on the call today are probably like that lead penguin, right up there at the very front. And really our job is to really be able to focus then on those other penguins that we can lead to our little change journey right here. And, when we do that, we're able to then kind of build a better foundation to help each different person along where their journey may be. The next picture I wanted to show is really, you see some of them are saying, why do I need to change? What are they doing? I think if we build the right foundation, those penguins, kind of come along. What the most important thing I think it always really boils down to, first and foremost, is to share the story. Chris, can you still see the share the story?
Yes, it looks like you are good to go now, and things are moving.
All right, wonderful. So I think when we share a story, especially if the storyteller is somebody, of respect and somebody we really appreciate. This is a picture actually of a couple of physician surgeons who are surgical leaders in our organization. And they shared the journey from different events that they've had that may have been a little bit of a challenge and traumatizing. And one is actually our OR director from one of our safest medical centers in Kaiser Permanente here in Southern California. Another is our director of research. It's really about finding opportunities to be able to share the stories. In our organization, every 2 weeks, we have something called a safety huddle. And I know many individuals who are on the phone call right now participate and listen on the safety huddle. And really what we ultimately try and do is be able to take events that have occurred in our organization, be able to share some of those analysis and some of those learnings, focusing really on a very comprehensive system analysis. When we share these events, it really is within the framework of a just culture algorithm, because we always want to find opportunities to be able to promote that balance between individuals and the systems. And last but not least, to make sure we're also taking care of our providers who are involved in these events, because we know that they become second victims. When we're able to do this, in a standardized fashion, one of the things we do is create basically an S-bar from each of our stories. So our very outstanding risk directors that work in our Southern California region create kind of like a way of being able to disseminate this information with clear action items that our frontline providers could take. And one of the ways that we've been able to disseminate that really to our frontline staff is creating these little video modules. What you see right here is a little video presentation that kind of shares and depicts some of the events that commonly occur. We're just showing kind of the operating room. But what you see, this is an opportunity now, whether you're on a Zoom call or we do Teams in Kaiser Permanente, to enable our surgeons to speak up, for them to be able to really understand what happens during these events. And every single one of those little mind bubbles that you see, those are actually all of our surgical staff kind of sharing what their thoughts are and reflections. So now you're really visibly able to show exactly what's happening and to be able to get people's input. And, and the notion of providing input, these are an opportunity to produce survey questions These are actually 4 questions from Kaiser's version of the Safety Attitudes Questionnaire that is usually given to our staff, and it really is just to gauge where people feel about their speak up culture, the culture of easy to learn. So it's very important when you do provide any educational tools in the way that we do to really even allow your surgeons and allow your physicians the opportunity to share how they feel about their culture, because sometimes I think we almost leave physicians out of the entire spectrum of where do they feel about their own culture. And you can see even just the way that this is stratified, some feel everything's great, but there are those that feel like there's room for improvement. So building that feedback system is so critical. When you also do that, what you now are able to do is build a system of data and a little bit of feedback. So we always say, the stories are really the what connects you emotionally, but it does help to be able to have a system of data to be able to back up the story, because data is actually a story in of itself. And this, you can see, obviously, we've built a system of monitoring the different domains of team steps when we're doing procedures in our different areas. So this is actually a very large comprehensive program we've done to be able to really validate what does team steps look like when we're doing procedures. So you can see it kind of goes up and down, but the idea is an opportunity for us to be able to validate how our team steps implementation is. So we've gone from the story. Now what we want to do is dig deep a little bit more and really think about errors, because invariably people are going to start thinking there was a mistake, there was an error, somebody screwed up, and all those notions of what happens as human beings come into play. So I kind of use this joke, we like to reason with Swiss cheese. And what do we mean by that? Well, it all comes down to this gentleman right here. This book is actually a big reason why I wanted to actually have this discussion and do this presentation. This is a terrific book. I highly recommend it. It's actually quite short. And this is basically Dr. Jim Reason really kind of giving, a summary of just error. And I think those of us interested in human factors and safety really can learn a lot from this book right here. But really specifically within the culture of medicine and healthcare, I think he really brought up some very important points, namely that healthcare training, particularly that of doctors, is predicated on a belief in trained perfectibility. And as a result, that ability to be able to train perfection, medical errors are marginalized and stigmatized, and unfortunately compared to, say, aviation and some of the other domains, it's almost equated with incompetence. So I think there is a professional barrier that is almost trained and ingrained for us to not accept or not talk or not be able to accept error. Well, if it wasn't even hard enough for us to be able to professionally accept error, then we have to be aware that just as human beings, or maybe even not human beings, that it's almost a part of our nature just to blame. To make a mistake is human, but to blame it on someone else, well, that's even more human. And even the cats apparently seem to have adopted this behavior too. Sorry for the cat lovers. But I think if we look back on our journey about talking about error, I think most of us do know the Institute of Medicine report in 1999. It really kicked off our patient safety journey. And I'm not going to go into the details in the first 3 bullet points. Those are all the details. But I think most importantly is the bullet point on the bottom. More commonly, errors are caused by faulty systems, processes, and conditions that lead people to make mistakes or fail to blame. That really was almost the kickoff of what we now know to be our Swiss cheese. So that's the reason why I say reason with Swiss cheese. The first layer of the Swiss cheese, these are the latent safety factors. These are the things that really we don't have immediate control, but it has such a profound impact on us. There's a culture that we work in. Is there a culture of psychological safety and accountability? How about policies? Do those policies lead to processes that are clear? And ultimately, it's the practice. How do these different elements lead into the practice? Let's now look at that practice slice. And the practice slice is really where most of us really operate in. What is the level of training? Is it inconsistent or consistent? Are there workflow variations? Well, Dr. Cheng likes to do it this way, but Dr. Smith likes to do it that way. How about communication? How often does communication not really happen in a standard way? And last but not least, then there's the actual action that unfortunately leads to a bad event. So when we're thinking about the different options for how we can help mitigate these, then we're going to look at our team steps. This is where potentially cross-monitoring to make sure we stop something before it actually happens and plug in those holes. What about situational awareness and how that affects communication? Why we practice closed-loop communication and plugging up those holes right there. How about the opportunity to maybe look at our variations and find some level of standardization, and the opportunity to be able to use our briefings and our huddles and our debriefings to really explore some of those opportunities as well, to plug up those holes, and looking at a variety of different ways of doing training, especially in our different ways of working in this virtual world, by being able to plug those holes up. So now what we're trying to do is be able to use our team steps and some of our basic process improvement to be able to now work upstream, to be able to hopefully help mitigate those bad events from happening. Now, when we're thinking about opportunities to be able to talk about error and to be able to think and really process and understand error as if we were studying a disease or studying, pathology, I think it's very helpful, especially for me, I would think as a physician, to really be able to understand and study error rather than just have a knee-jerk response to error. Whether you are at a root cause analysis or maybe physicians are doing a case report, quality improvement opportunities, journal clubs, there are multiple opportunities to be able to really bring the conversation and the understanding of error into the areas where physicians really have discussions about specific things. This is a very famous slide taken from James Reef's Human Error. And one of the things I think is always really helpful, and I look at the basic error types of slips, lapses, mistakes, and these are basically attentional errors, memory failures, and basically just different ways in which us as human beings make errors. I make about 90% of these just in the kitchen when I'm getting up in the morning. And I think if you're able to have healthy and even funny conversations, the connection between these human organisms and the way that we make error and how that translates into our work environment, I think starts to become a little bit more clear. The most important thing I think it really allows us to be able to do is if you look at the types of errors that occur, they result from attentional failures, memory failures. This now gives you an opportunity to better devise systems and ways of solving specific issues that occur. So now we're able to study an error, talk about the error, and understand really the mechanism of how errors occur. So now we can actually start being more proactive. So what we've now done is create an opportunity instead to talk about errors and feel like blame from errors, is now creating a culture where we can identify near misses and promote good catches. So we're now talking about using the Swiss cheese to actually start becoming more proactive. So from one event, we're now talking about good catches. Creating a good catch really helps us to really model that leadership because now we're being proactive in that conversation. It allows us to cultivate communication. Hey, Jane, I almost had a near miss, and what do you think would be a good way that could not happen? Now you're inviting people to really kind of provide their input and block that part of the hole up. And now we're also looking, maybe now we have an opportunity to look at our workflows, look at our policies, and maybe be able to block that up. And ultimately, this is creating a culture of resilience. And I'll go into these two individuals. That's obviously Sully, and that's First Officer Jeff Skiles. And really, ultimately, what we're trying to get to is start going from a culture of blame and shame to a culture of good catches and learning. So let's take a little bit of a deeper dive and understand, now that we're talking about errors, let's understand, why do errors even occur and what is it about our limitations as humans? I'm going to go into team steps language a little bit. We love talking about situational awareness and situation monitoring. I think when we talk about situational awareness, there's an opportunity really for us to think about our own awareness and what are the things that limit our own ability to be able to really make some of our decisions. I have to highlight the work of Dr. Marjorie Stiegler. Cognitive processes and the discussion of cognitive bias and errors are very, very much part of in the anesthesiology world. You're more than welcome to take a look at this article. But in this specific article, as well as this very, very famous book called Thinking Fast and Thinking Slow by Daniel Kahneman, there's a lot of discussion in how our cognitive biases and the way that we think, or the way that we don't realize how we think, really play into the way that how it affects our relationships at work, the decisions that we make, and there's just so much that happens that we're really not completely, aware of in the background. This is actually a picture that I grabbed from our own Team Steps module. But what I want to think about is cognitive bias. It's almost like those blind spots. You see some things, but there's a lot of things that carry around with you that you just aren't aware of. And some of the cognitive biases that I did point out that I think are related in the patient safety part, really, number one would be anchor bias and confirmation bias. And that's really just our human ability to automatically want to hone into what we think the problem is. And when we have those biases, it almost doesn't allow us to tune in what other people might be saying to us. Availability bias, you're making that decision just based on the information you have right now, right here, and not able to really think about what else somebody else might be saying. Are they speaking up and letting me know that maybe we need to wait for another decision? Ascertainment biases are very, very important. We may have prejudices. It may be not just about somebody based on their race or their gender. It could be based on the experience we had as a patient. How often have patient safety reports started with that frequent flyer patient or that nurse? Oh my, yeah, OMG, here he or she goes again. Those are very powerful human things that affect our ability to process information. And I'll go into this a little bit when we talk about some elements in aviation safety especially, but the halo effect and passenger effect, which is all biases in which we kind of run into a situation, we assume somebody else is in charge, or we think we shouldn't be in charge because it's not our place to be able to speak up, or it's not our place because it's his or her decision. So those are all very powerful biases that affect real-life decisions. I don't think we can necessarily solve our biases, but I think an awareness of it allows us to almost build in that blind spot indicator that hopefully should be going off. This is something I want to share that I'm very, very proud of, in Kaiser Permanente. We've had an entire team, and these are all different leaders in our Kaiser Permanente organization, have a focused effort on improving diagnostic reliability and minimizing diagnostic errors. And the reason why this is very important, and that link that you see up there, you are all welcome to click onto that link and go through this little mini library and that our organization have put together. It was really basically to talk about how the very same things that prevent us from making the best diagnostic decisions that we can possible are in fact very similar to a lot of the things that happen to us in patient safety. And I think more and more, many of you I know are on the phone really are involved in both safety and quality. The crosswalk really between both safety and quality are very, very common. The fourth box from the right is about understanding bias. So I gave you a little bit of introduction, but there was a vignette about all the different types of biases. So this was specifically designed for our physicians. It was extremely well done. I actually will end off the presentation with one of the videos from this video library. But it really gives, a great resource of different ways in which the way that we think about how we think really affects, and even how important it is for us to really listen openly to our back office team. That diagnostic is a team sport, so this practically could be team steps right here. So I highly recommend you to check this out if you'd like to. Individual awareness. We talked about how to talk about stories, how to talk about events, why errors occur, and really what are individual barriers, and how does that affect our ability to be able to work together as a team. And I think if you ask a lot of people, especially if maybe a few doctors here and there, especially the ones who picture we saw a little earlier, and say, why are you talking to me about teamwork, Jason? It's been an issue. I have a great team. Well, for lack of a better word, and this is a little bit tongue-in-cheek, I love this button. Teamwork is a group of people doing what I say. So, it wasn't actually just a few years ago that this happened in 1972. Those of you who study patient safety, I think, do know who that gentleman is up there and why I'm showing this picture. That is Captain Jacob van Zouten. He was the lead pilot trainer for KLM. This is back in the 70s. So I would just ask you, if you were sitting down and you knew that this pilot actually was your pilot of your plane, how you would just think, man, I'm in the best hands. I've got the best captain, the best pilot, and he's in my placard. I'm sitting right here. But lo and behold, I think some of you guys may have known, he was actually responsible for this accident. This is the Tenor Reef accident that happened. That was probably one of the most watershed incidences in aviation history that really kicked off the entire crew resource management history. And when they had done a little bit of a deep dive and really understanding what happened, although there were multiple communication errors and what have not, ultimately what they really felt like it was a lack of leadership. He felt like because he was the captain and he was a trainer. The halo effect and the inability for all those around him to be able to speak up and tell him you have to stop didn't occur, and it really resulted in probably the most tragic accident in aviation history. I include that link that you see on here because there's a very, very beautiful depiction of all the elements of what happened on that tragic day that led to it. So it really is an amazing video to watch by any stretch of the imagination. So I love aviation, in case that's not terribly evident at this point. Here's a little story for you. I think you probably know that was me, the guy over on the left. The guy over on the right, however, is much more important in the entire story of what I'm going to discuss. This was actually at the AHA team conference in San Diego. I had an opportunity to be able to present with a co-pilot of mine. And this gentleman right here is First Officer Jeffrey Skiles. Yes, Skiles as in Sully and Skiles. I had the wonderful opportunity to be able to sit down with him the evening before, and we had dinner, and it was probably one of the most memorable dinners I've ever had in my entire life, to be totally honest. But what really, I think, made me just complete amazement of Jeff is the fact that this guy was one of those his level of humbleness, his humility, his humor, really just spoke, to what the aviation, I think, culture created in terms of leaders. And I remember one of the first questions I asked Jeff when we sat down was, so why were you chosen to be on that flight that day with Sully at your side? Because I know this is just, this first time you guys even flew together. And so I made it very deep and profound. And Jeff said to me, I don't know. I was just there for the ride. And I was kind of a big chuckle on my part. And, just to even say how more humble Jeff was. Jeff says, I know I'm here to speak, but to be honest with you, I'm the worst public speaker in the world. I actually get nervous, and I can't even manage talking to my daughter's Girl Scouts. So it really was kind of an interesting moment. But when I got a chance to really do a deep dive and really kind of talk to Jeff about ultimately message he has for us in healthcare, he shared this actually at the conference in the keynote that hopefully many of you guys were there to listen to. What he really mentioned was, in order for aviation to be as safe as it is, it was really dependent on the recognition that pilots needed to embrace their role, not just as a technical leader, but really as a team leader. And I think that was a really big epiphany, at least for me, that this was just something that, we would have to go through on our own journey. So here we are. Obviously, we knew Jeff was here to talk about this miraculous story. And, from where the Tenor Reef accident happened to about this incident, it was really almost like a 30-year journey. And when I talk about a journey, this is a slide that we actually shared in some of our other Kaiser Permanente presentations. This was all the way back in 2009. This really shows the journey that aviation went through in their crew resource management learnings. And you can see it started all the way back in the 70s as a result of some of the watershed incidences, just like what had happened in the Tenor Reef incident. But what I do want to highlight right here is you could see almost right from the get-go, they knew they had to focus on the leadership part, because ultimately everything really in some way started from the leadership level. And this was the CLR actually stands for Command, Lead, and Resource. This was a very generous gift my co-presenter, Captain Richard Martinez, who used to teach the United Airlines captain course, had given me. And what this is, even though it looks like a little placard, and I'll show you actually a little bit more detail actually what it looks like, just a quick little flashback. Captain Rich and I did present on a prior AHA Team Training Monthly webinar. This is actually back in August 8, 2018, after we did our San Diego presentation. And you are more than welcome to go and listen to that. We really talked about leadership and followership from the aviation safety framework. But I want to show this placard a little bit. And I think what really, was very, very incredibly enlightening was the fact that you see right there at the very top, this is the captain remains in charge. This guide empowers all crew members to be able to speak up on any issue during, before, or after a flight. It is a tool to encourage discussion as communication can resolve problems. And then if you look all the way on the bottom right here, I'm going to go ahead and highlight this for you too, that CLR has taught flight attendants the elements of inquiry and advocacy. Listen for these as well, the cuss words: concern, uncomfortable, and safe. And I think what really is very incredible about this, if you look at all the pieces actually of this toolkit that was created for the United Airlines Captain's Training course, it really is team steps almost on a placard right here. And one of the things is really it requires training. If you think about it, none of this is intuitive, especially to us as, human beings. It really took an element of training, really from the top down, from the bottom straight up, to be able to create this kind of culture. But I think what this toolkit really represents is what makes you a better leader, what makes you technically the captain, is that you empower your team. When you empower your team, that is what makes you truly a leader. And the bottom part really about the cuss words that we're all very familiar with in team steps was really the importance of having an understanding of that shared language is what allowed everybody to have that mental model. So technically, it really kind of took the narrative, the old definition of being a captain or a leader says, I am the captain. I need you to listen, do your job, and do what I tell you, and just do your job. It kind of went from that place, which is maybe where Captain Van Zetten had come from back in his culture, to creating a different culture where it is now, as Sully and Jeff were depicted, as a captain, I need you to cross-monitor me and speak up if anything is of concern. And I think what that really boils down to is what Jeff's ultimate message to all of us really was that flying a plane definitely makes you a pilot. And anybody see the name badge on who this pilot happened to be? Yep, it's a little cloudy, but it does say Sullenberger. So that is a young picture of Sully as a pilot, but ultimately, leading a team is what makes you the captain. And of course, I think all of us recognize Sully there with Jeff at his side, with Donna, Sheila, and Doreen in the back. So that is truly the team that I think that makes Sully the captain. So I wanted to stop for a second. I have a really, really great video. I think I went relatively quickly, but I wanted to make sure we get some time to kind of watch a video from that library I shared a little earlier. And I think what frequently happens is, we get very inspired when we see, depictions of heroism like Sully, what have not. But if you put all the elements that I've discussed a little bit earlier about teamwork, about bringing everybody in and creating that psychological safety, what does it look like when a regular, physician from our organization really, truly model that, and how does that affect the culture of everybody around him? And the video I'm going to show you actually comes from that Kaiser Permanente library. And it's actually a good friend of mine, Dr. Rossdorf. So with further ado, go ahead and show the video, please.
Grand Rounds are a forum for physicians to discuss cases and share learnings with colleagues. Kaiser Permanente Orange County is currently piloting Grand Rounds and other forums to expand our opportunities to discuss cases in a supportive environment. Lunchtime WebEx learning sessions in the primary care service line developed by Dr. Andy Cheng have been in place since 2013. This serves as partnership between primary care and subspecialty to enhance patient care and streamline care delivery. LEAP, or Learning from Practice Grand Rounds, are a novel way of discussing cases with multiple disciplines and multiple specialties to create new learnings and understandings. Our Grand Rounds discussion often highlight cognitive errors or pitfalls that impact care. LEAP Grand Rounds is a unique opportunity for us to bring teams together. We take care of patients in teams every day, and this is an opportunity to build up those teams by examining the care that was provided to an individual patient. Over time, this helps lead to better psychological safety for folks to speak up about care they see in their everyday environment. In addition to a safer culture of speaking up, we also generate better team situational awareness. Essentially, the team mind is better at providing care than any single individual. LEAP Grand Rounds is a way for us to connect individuals so that they feel more comfortable speaking up. Also, in order to get an accurate diagnosis, we usually find that more minds are better than one mind. And we can't have a discussion unless everyone in the room can participate. So the hierarchy of care can sometimes stifle free movement of ideas amongst all team members. LEAP Grand Rounds have brought the nursing staff and physicians together in a collaborative and collegial environment that fosters team building and independence. After the last Grand Rounds, we were able to have a debrief session with our nurses, and this is what they had to say.
It's important to have both physician as well as nursing judgment and consideration brought into the discussion.
It's got to be able to satisfy quality and safety too, that what we're doing is actually providing a value that the whole
We
system.
had to stand up when a doctor came in and give him our chair and get him a cup of coffee. We did all this stuff, take off our stethoscope and, So this really does break it down, and it's easier for a nurse to talk to a physician of specialty, and it just really is a nice way to have nursing and MD relationship.
The biases that we can see in diagnostic error, which is one of the focuses, is how do we overcome our own sort of thinking. Our guidances for avoiding those biases is really form a really broad differential diagnosis, like try to think as much as you can outside the box for physicians, for nurses.
Maybe you've got a doc who's out 5 years and you've been a nurse for 25 years. You've seen a lot more, and to be able to say that, and I think that's also part of the comfort level.
And I think that's the thing that kind of holds a lot of people back, is that, you see this stage, like it's a hierarchy type system, but the culture is changing, we're evolving to that, So now it's just like everybody kind of blend in together.
What I'm hoping to break through on is that we have that culture that's beyond sort of the leaders or the key representatives, because sometimes it's just like the chosen few. To me, that's the key, that if we sort of, in a sense, drop your role at the door and you come in with that, hey, you're just entering this learning environment. And I think the quality and safety side, we just really need to protect that.
This is a teamwork, that we are here to work together for the better of our, patients, the community, I think selling that idea and selling the idea that we are professions where we need to grow, we need to grow, we need to learn. That's how, we can better take care of our patients.
So you can see from the comments of our nurses that bringing teams together to talk about cases leads to better psychological safety and hopefully better care and diagnosis for our patients.
So what I wanted to be able to do, I think, just kind of summarize, some of the main elements. I think I wanted to start off most importantly just by acknowledging how important it is, for us to be able to just create conversations, even if it's with a few people, to kind of create that gradual change, just like those little penguins. And sometimes even if you don't have that many people or that many physicians who you feel like can really kind of help you, just focus on one at a time. Number two, like I said, stories are what connects us. It is what really binds us. And I think having a few very, very brave people, be vulnerable, leaders to be vulnerable, share their stories, or have other people share other stories, is really key to be able to kind of get people to open up. If you have data to be able to support the stories or be able to kind of help bring the scope of the problem out, then that creates a little bit more of an urgency, and it does allow you to kind of connect that, the mental part of the processing. When we talk about errors, when we talk about things that happen and mistakes that we make through those stories, I think it's an opportunity for us to really try to take the blame and shame focus that automatically sometimes is instinctive, but really go through the science of errors, with Dr. Jim Reason's, theories, some of his Swiss cheese, elements that he goes into, and being able to really have a discussion about how to be creating now good catches, how to be able to look at near misses and be able to create resilience, as a result of doing that. Having some time to think really about our own awareness, how our own individual awareness really affects, the team situational awareness, I think is really key. I showed that video a little earlier, as well as that library that we have for our organization, because the same things that allow us to be safer actually are the same things that allow us to be able to make better decisions, make better diagnosis, and really be able to improve the quality of care. So you're able to really tackle the same issues, but really take it beyond the scope of just safety, which some people may not really understand, but be able to think about how this actually applies also to your quality improvement work as well. And last but not least, I think when we're able to put all these conversation pieces together and be able to allow our physicians to really understand their unique role to be a team leader, just like in the way Dr. Swaroop did, showed in that video, allows us to really understand that, collectively, if we work together, if we empower everybody to speak up, even those who feel like they don't have or are not in the place to speak up, everybody ultimately benefits, the physicians, the nurses, the staff, and most importantly, the patients. And when we can do that, in small little bite-sized opportunities at a time, that's really when you start to gradually change the culture. So with that, this is my last slide right here. I think I talked a little bit about penguins as being really an important part of our change management journey. And I think the most important thing is not to try to take too much at one time and boil the ocean, but really just focus on one small win and focus on one small little step at a time. Because it is a journey, but I think as long as you take those little small wins and build your team little by little, that's when you know you're going to get into the right direction that you're going to. And with that, I'm going to go ahead and stop. I've shared a lot of resources that you guys are all more than welcome to go through in the slides. And if you have any questions about some of the stuff that we share, some of the tools, the videos, the training programs, feel free to reach out and email me, and I'd be happy to answer anything that I can. So with that, I'm going to send it back to you, Chris.
Thank you so much, Dr. Cheng. That was great. Wonderful presentation. Definitely have some questions that came in, and folks, please continue to chat in your questions as we go. But wanted to take a moment here to look at some of the things that have come in. One of the things that you had shown early on was that it was like an error algorithm that had, the different types of errors that you might make. And somebody brought up that it paired really well with the just culture algorithm. So is that something that you've merged together, or have you thought about that?
Yeah, no, absolutely. I'm glad you brought that up. I think the just culture algorithm really is paired beautifully with Dr. James Reason's depiction of the different types of errors. So absolutely, I would say if you have the opportunity to be able to pair the just culture algorithm, because the just culture algorithm really speaks to the system accountability of those latent safety factors, with how errors occur, with us who really work within those systems. So absolutely, I would support that.
Good deal. So looking at cognitive bias, so you have a lot of great tools that you are sharing via the Kaiser website, so that's wonderful. Somebody asked the question, though, do any of those tools help evaluate what a team member's cognitive bias might be? Because I understand that everybody has some cognitive biases, but is there a way to evaluate what they should focus on, what blind spots they have?
Yeah, that's a really great question. I think that this is where I think healthcare, unfortunately, has been a little bit behind the eight ball when it comes to human factors. Cognitive bias is very, very mature. In some of our other industries and some of our other sciences, I think the first reason why we started this conversation around cognitive bias is just because it was not necessarily something that we were trained to understand when we were in our schooling or in the indoctrination. I think that is where we would like to get to. I have grand ideas, so maybe in a couple of years I'll be able to really kind of implement it. But I think the first most important thing, especially, if you have an organization as large as our organization, is just to be able to get an awareness, of cognitive bias and to be able to allow people to really, I think, reflect and process how the different types of biases affect not just the way in which we may rush to diagnostic decisions, but even the way in which we kind of work. I think that to answer that question you just posed to me, Chris, really takes a thoughtful implementation process for how you would build the education, how you would build the review, how that process also has to be protected. Because obviously, we're probably in the most litigious state, country, maybe in the entire world. So I think there's a lot of thoughtful processes that have to go into making sure that when we talk about biases and train for cognitive bias training, that it is done, with psychological safety. So absolutely, I would say that's a big yes. And if anybody has ways in which they are doing it, my goodness, please let me know. I would love to email you and love to hear, how you're doing it. But Chris, I think, that diagnostic errors and the way that cognitive bias plays into that is becoming very, very large discussion area in patient safety in general. So more to come on that for sure.
Sounds great. Yeah. I know that there's some questions here that are coming in about crew resource management, and one of the things that I have a question on is I know that, they in the airline industry are past crew resource management and are in that threat and error management element. So, how are we, I know this is something we talked to Skiles about in San Diego, but how are we making that next step forward, right, to go to that next level like the airline industry has? Any thoughts on that?
Yeah. No, I think there's two parts to this. I think one, there obviously has to be some larger stakeholders that I can think are kind of involved. Aviation is highly regulated. And if you look at the history of crew resource management did not come actually from the FAA trying to say we have a problem and let's fix this. It came from so many stakeholders involved, federal, commercial, legal, and actually I would have to say the main body that really allowed crew resource management to even exist, it was not even the FAA, it was actually NASA. So I think it does take a third party that does not hold the sticks and the penalties and the punitive measures to be able to almost execute something like that. So I think on a larger, bigger picture, that's something that needs to happen in the healthcare, industry. I mean, we have terrific organizations like, Joint Commission, Leapfrog, and a lot of these other organizations. So I think some work has to be done at that level. Now, speaking more just, in terms of like a micro level, I think what it really boils down to is, again, leadership. You have to have C-suite, level of support. We really can understand how important, doing leadership training in the way that, Captain Martinez and I shared back in San Diego was important. You don't have to do it, in like a gigantic 4-week training, but small little bite-sized ways. So this way your leaders, we're very busy people with a lot on their plate, understand, bite-sized, little by little, how to be able to create these connections and build the right process to motivate the right behaviors and kind of build it from a change management methodology. So again, very much change management principles. I think just supporting the leader, giving them the right tools, and working both from the ground up as well as from the top down.
What are some of those, tools that you can use that really help the physician embrace their role as the team leader? I know that something that people have said to me before when I've talked about crew resource management is, well, of course a pilot wants to change because their life is on the line, and that's not the way it is. But, I think that a physician's life is on the line with second victim syndrome. So, there's a lot of resiliency there, and there's obviously a high rate of physician suicide and deaths of despair. So, how do you encourage that? How do you make that change or encourage people to make that change? Great question, Chris.
So if in the very beginning, a little bit toward the beginning of my presentation, I did share that when you can take a single event and be able to really cascade that story to your physicians, for instance, whether it be a Zoom meeting, whether it's a department meeting, creating venues and forums for them to really have those conversations allows them, I think, to really kind of go through like this group therapy or almost individual therapy that is almost kind of needed to be able to process exactly what happens to them on a day in and day out basis. I think finding the opportunity to have those conversations, number one. Number two, I think when you have surveys, if you can have them fill out quick little surveys. I'm a huge fan of surveys that really get to the crux of some of the same questions. So I had shared a couple of slides that showed, questions asking, is it easy for you to speak up about your errors? Is it a culture in your department? So by finding opportunities to allow, people to be able to speak up with some level of immunity and psychological safety, I think those are really key to create those vehicles for people to speak up. So creating surveys, creating little videos. If physicians have the opportunity to do interprofessional training or even their own training, something very, very effective, because I know we have a lot of people who do simulation, is do a simulation, but put a camera as if you are the patient, and then record that, and then show that recording from the patient's vantage point, from the patient's perspective of what it's like to go through the different levels of care. I think we get so stuck into our daily work. We're just trying to rush and do the best job we humanly can. But I think what happens is if you find opportunities to live through the eyes of being a patient, it completely transforms the way that you think about your work, and you realize actually ultimately what's at stake is your patient. So anything that allows you to really be able to look at the event, share the story, create safe conversations, and really try to bring the eyes of the patient directly into it. In that library that I showed, the Kaiser Permanente library, actually the second video that I didn't talk about actually was a patient who was, and her family, a victim of a diagnostic error. I think whenever you could bring the patient into the middle of it, it allows everybody's differences and everybody's different viewpoints to be put aside, and it really is a great way to center and start all the conversations.
Are you seeing this, these ideas, are they filtering into medical schools, or is this a part of the training? Speaking of simulation, are these kind of thought processes getting into education that way?
Yeah, absolutely. I don't work too much in, undergraduate medical education, but, for our school, Kaiser Permanente does have a medical school that we actually just started. And the first gentleman who's actually in that library vignette series is actually Dr. Michael Cantor, and he actually made it a point to put cognitive bias training, error reduction, human factors, and all the elements that were really is into it. He brought that into the medical school. They've actually adopted a methodology of the flipped classroom into the teaching for the medical students. And I would just imagine, Chris, that, there are other medical schools and other residencies that really are starting to kind of go into that direction as well. So I am pleased to hear that I think that is getting into the curriculum, because the socialization and the indoctrination of professions plays really such a huge role in shaping how we think about our biases or don't think about our biases. So I think I do see that starting to happen.
That's great. Well, I'd like to thank everybody for attending today. Thank you, Dr. Jason Cheng, for the great presentation. Thank you to our friends at Relias for sponsoring this. Everybody, you'll receive an evaluation form that will be sent in your email shortly, so we'd love for you to fill that out. And on screen again is the information about the Duke OneLink account and how you go about getting your continuing education credit. So I'll leave that up so you can make sure to grab that code and the phone number. You need to do it within 24 hours. Very soon, in a couple days, we will have this presentation will be on our website, so you could see a recording. I know that some of you had issues with the video and hearing it, so you'll be able to hear the video in there fully. That will be a part of the recorded presentation. So without further ado, thank you everybody for joining today, and we'll see you next month.
Thank you, ladies and gentlemen. This concludes the presentation. You may now disconnect.